So whom do we have today? We have Dr. Kanyon Keeney from the US. Dr. Keeney received his DDS and graduated with honors at a medical college in Virginia in '84. And he completed his residency at the University of Pennsylvania in oral and maxillofacial surgery in '87, where he served as a chief resident. He maintains the practice in oral and maxillofacial surgery with the concentration of implant surgery and bone regeneration. And till now, you can correct me, Dr. Keeney, he placed more than 18,000, probably 20,000 implants. And he, beside this, is a fantastic speaker on the local, state, national, and international level. And today we have him with us. He will start his first presentation with the graft selection for ridge augmentation, followed in the second half an hour to the patient acceptance of allograft. We all have sometimes the problems in our practices. What is the acceptance of the patients to the allografts we are providing? And I'm excited to have you here. Welcome, Dr. Keeney. Thank you for your time. And the stage is yours.
Thank you. Thank you. I need to share the screen. There we go. Beautiful. Thank you. And there we go. All right, here we go. Beautiful. Can you guys see it? All right. It's a privilege to be here, especially with such an esteemed group of doctors all over the world, and particularly for LifeNet Health. LifeNet means a lot to me. They are in my home state of Virginia here, and I've had the privilege to be able to visit their phenomenal facility there and learn so much more about what it is that we do. I'm of course going to talk about graft selection for ridge augmentation, and I'm going to clarify that I utilize multiple different types of graft materials. I'm in a group practice of 11 oral surgeons, the second biggest one on the East Coast of an oral surgery practice. And I particularly subspecialize in bone grafting and dental implants, as was mentioned before. With that is the requirement to do a lot of regeneration grafting. A lot of cases are sent to me that require regeneration grafting because otherwise the dentist would have felt comfortable placing the implants themselves. But also in the process over the decades of doing this, I've utilized predominantly allograft. Though Xenograft is a very important part of my cases, particularly in the anterior maxilla. But discussing these with patients is as much of an art form as it is a science. So I want to share some of my experience about there. And I'm going to clarify that I've done a lot of cases, but I'm actually my partners remind me, I'm just a hedge above mediocre in terms of skill set. My only advantage is a large N. With that comes a lot of anecdotal experiences. So of what I'm going to tell you, there's some science-based, there's some evidence-based, but a lot of it is just my anecdotal experiences. Do not feel uncomfortable totally disagreeing with me. Do not feel uncomfortable going a completely different direction. The only thing I can show you is how you can have success in a large volume with a large number of patients on a consistent basis. In implant dentistry, it's important to note that though profitability is second to our interest in clinical excellence, it turns out in private practice that what is clinically the best for the patient and the most efficient, including the least number of office visits and complications, ends up being a much better business model as well. So we are now dealing with a lot of things with the pandemic, and that is a huge amount of stress. And our lives, all of our lives, particularly now with the second and in some places even a third resurgence taking place, we have to contend with things that we can't control. And these things that we can't control in our lives circle around us in such a crazy way. And as they circle around, we have to focus, if we can, and not get distracted by the things we can't control, and focus on the things that matter and the things that we can control. And for the record, there are things that we can control that really don't matter. Like, for instance, the flavor of latte I had this morning from Starbucks. There are also things that matter that unfortunately I can't control. But as we stress and focus and try to endure through this process, if you focus primarily on the things that matter that you can control, life gets a lot simpler. And this is a real important mantra for me on a daily basis when I get distracted. And so all those things, family, ourself, our own personal health, our practice, our staff, the team, my collaborative team of doctors I work with, and most importantly, of course, the patients. These are my partners. I have 11 partners altogether, 10 other partners. One is retired. The guy in the center there, Joe Naamtu, is the most famous oral maxillary surgeon in the United States for facial cosmetic surgery. And he subspecialized away from full scope oral surgery as I did. And he led me sort of in a business model as well as an ethical clinical model that even though we have quite a different discipline, there are certain protocols that we have to carry out. All my partners, we've worked hard to make, to endure through this COVID process. We built this brand new cosmetic surgery center and dental implant center, and it was scheduled to open 2 days after the governor of Virginia closed all elective surgery down for 2 months. And of course, the mortgage still had to be paid. We did not get delay in the mortgage. But we couldn't control that. All we can control is how we focus and communicate with our patients. Now, here's the most important message. The need for our services has not changed. The people that needed us before COVID are going to need us after. And strangely, I have seen a huge increase in demand since we started back in elective surgery. And I'm not sure as to the etiology of this, but a lot of my colleagues in different disciplines within dentistry have noticed that their volume and their patient scheduling is more than it was before COVID. And I don't know if people are using their money on dentistry rather than going to Disney World, but in the end, all I know is the demand has increased. And I don't believe this is a temporary phenomenon. More importantly, we have to step back and look at the forest for the trees. There's a huge opportunity here for us to take time. These three numbers, these are US numbers. So I'm speaking to an international crowd, so I'm not sure of the data in your respective countries, but there are 40 million people in the United States that are edentulous in at least one arch. There's 178 million people out of the population of 350 million that are missing a tooth in the anterior aesthetic zone or in a prime first molar bicuspid functional zone. 66 million people in the United States are considered to be in a terminal dentition. So the American College of Prosthetics reported this, but what they also reported is that only 6.5 million dental implants have been placed in the United States. So there's a huge opportunity here, as I'm sure there is around the world. We have a lot more to do. The interesting thing is the need is powerful. And if we try to look beyond those things we can't control and focus on the things we can and use this opportunity, if you're closed down, use the opportunity to ramp up your skill set, to be able to change the physical plan, change the way you do your communication with your patients, whatever you have to do. But this is not, this is an opportunity for us to change the way we do things if it's necessary. So if we're going to do more implants, implants need bone. And when I became an implant doctor in my local area here in Richmond, Virginia, that was code for all the dentists out there to send patients that need bone to me. And that's good and bad. It's a tough practice to have, but it also forces you into efficiencies and to anticipate complications that may arise. And it's a very complex group of things that make a success. We know all the science, but the social science and the communication with the patients and understanding the patient's needs and wants, but also anticipating the patient's ability to be compliant with what you do. Nothing magnifies that more than bone augmentation. The most time, the most complications. My practice is, I used approximately 59% allograft alone on my grafts. In other words, the case was 59% of my cases were 100% allograft. Approximately 16% of my cases, and by the way, this is 3-year data. So this stands from 2017 through 2019. So this is not up to date for this year. 16% of my cases had both an allograft and a xenograft combination, 13% xenograft alone, 10% were allograft, excuse me, that should be autogenous bone alone. I apologize for that. 10% of my cases were autogenous bone alone, and 2% were alloplast. In this, about 40% had some type of biologic, and I'll discuss that just a little bit more. 75% of my graft cases, which makes up between 15 and 25 cases, small and large, per week, have allograft involved in the case. Now, Many of them were just socket regeneration and preservation. Of my socket regeneration and preservation, preparing a socket for a future implant, about 100%, if not 99%, were allograft. I've just found that it is replaced completely by bone, and if I'm going to put an implant in that socket, allograft is the way to go. Allograft is not the panacea. There are downsides to the allografts we have to discuss from a clinical standpoint that we have to engineer around. Gated bone regeneration, both vertical and horizontal, sinus augmentation, soft tissue grafting, biologics. These are all part of my practice on pretty much a weekly basis. I do sinus augmentations almost every day. I don't do soft tissue grafting almost every day. I use GBR almost every day, and I do socket preservation grafting or regeneration grafting almost every day or every day. So the minimal amount of grafts that you have to be able to do, in my opinion, if you're going to do implant surgery, is socket and ridge preservation, simple simple ridge and sinus augmentation. More complex graft, as your practice becomes more expansive, is large horizontal augmentations, combination cases that involve extractions, augmentation, grafting, and placement of the implant at the same time. And of course, vertical augmentation, both north and south. North, of course, is in the maxillary sinus, or it might be in the posterior mandible. South is the anterior maxilla, or and anywhere else where you want to take the maxilla downward. So which graft material to use? Well, it needs to be replaced. Does it need to be completely replaced by bone? I'll show cases where it is not necessary that it's completely replaced by bone, and the fact that it is not completely replaced is actually an advantage. But frankly, the majority of the locations that I work on that need to have an implant inside or circumferentially surrounded by bone, I prefer to use something that's completely replaced by bone. Of course, that's autogenous bone as well as allograft. Will it be in the aesthetic zone? Well, in that case, oftentimes I'll utilize a xenograft as part of the graft, because I have found personally, and there's some data that shows, and there's plenty of literature that discusses and explores this issue, but xenografts in conjunction with other treatments in the anterior maxilla has an improvement in not only the aesthetic long-term maintenance, but also somewhat to the gingival biotype. How long will it be before it's loaded? If I do an all allograft bone graft and the patient goes to Europe, where you guys are, or those in the Middle East or those in the Pacific, and comes back a year and a half later, it would have turned into bone, but then has already started the atrophy process. On the other hand, if there is a xenograft component, I found that it's much more stable from the standpoint of being the volume and the space maintenance that's taking place. On the other hand, the patient's in a rush. Here in the United States, we have patients that have insurance that expire in January or July, and they need this thing to be ready to go. And a lot of times allograft's better because, as most of you know, xenografts take longer to have outcomes. The timing issues are important. Does religion play a role? That's extremely important. Do I know how to use it? There are distinct handling characteristics and protocols that are different based on the graft material you use. Going back to religion, we have to ask, of course, what the mission is. Judaism, Islam, well, obviously porcine membranes, porcine graft material is an issue. Hindu, if they're strict Hindu patients, I have a lot of all of these. For some, it is important. From some, it's not, that bovine products are not utilized, as well as Sikhs. Jehovah's Witnesses, I don't know how they, or how many there are in Europe and other locations, but in the US, Jehovah's Witnesses strongly are against the use of human products. So we have to be respective of that. And quite frankly, most of the time, I will have a conversation. It may be only 60 seconds, but about the graft material, and let them make a choice, at least in terms of how it may affect their religious beliefs. Will my graft accomplish the mission? I have long time learned that having a single tool for a complex treatment often will leave me short. So I therefore have to have multiple graft materials available, as well as biologics, for the role that I do. Bone grafting materials, we all know there's only 3 ways that bone is developed: osteoconduction, osteoinduction, and osteogenesis. Quite frankly, about 80 to 90% of all the grafts that are available on a commercial basis in the United States are just merely osteoconductive. That's not a problem. We have to understand the format of such. Osteoinduction is obviously an advantage in certain cases, and a mixture between osteoinductive and osteoconductive capabilities is certainly wonderful. Osteogenesis, whether it be from autologous bone that survived the transfer from the donor site or from biologics such as bone morphogenic protein or other growth factors from PRF, PRP, these are all or stem cell products. These are all things that we have to know. But in the end, the complexity of all the choices we have, all of the proprietary commercial brands we have, all of the forms, whether it's powder, particles, paste, putty, block, they only work one of three ways, two of three ways, or three of three ways. And in the end, it's up to us, besides knowing how to use a product, and besides believing what we saw on a screen at a meeting will work great in your hands, we need to understand which way it is working. The materials, autogenous bone, allograft, which is of course fast, but is partially resorbs. Quite frankly, allograft in most cases, now this is an anecdotal, maybe dogmatic statement. For me, allograft works just as well as autogenous bone without a lot of the secondary hassles associated with it. There are some exceptions to that rule. The speed of conversion of autogenous bone versus allograft, there may be a slight difference, but it's not clinically relevant in my practice. Now, I love the fact that both of these are completely replaced. On the other is Xenografts, which I know in Europe has been around for a long time, as has alloplasts. They take longer to convert. They never fully convert, but it doesn't shrink as much. That's a generalized term that I like to use. Xenografts are important, and I use Xenografts every week, but it's important to understand for me where my strengths and weaknesses lie utilizing this. In terms of alloplast, much less than 2% of my practice is alloplast, but there's clearly use for these categories. Bioengineered components, stem cell products, bone morphogenic protein, platelet-rich plasma, platelet-rich fibrin, platelet-derived growth factors, enamel-matrix protein, stem cell products, and lately amniotic and chorionic stem cell placental membranes are all products that I have and are using today. However, I will tell you that the ROI, the return on your investment, for many patients you use this on is probably no different than if you don't. The key, I guess really the wisdom is knowing where you need to use this. And sometimes you may need to use these products just to expedite. Sometimes you'll need to use these products to compensate for some type of either systemic or local factor that can impede the capabilities. But in the end, most of these bioengineered products, at the very least, will increase the rate of soft tissue closure if used properly. So for me, it's the cost versus the benefit. In many cases, it's not worth the money because it'll be fine without it. But for me, because I'm an implant surgeon, that's also code for please send all of your sick patients and people with previous failures to this guy. And so for me, sometimes these do compensate for previous damaged sites or systemic impediments that make wound healing somewhat compromised. 7% of my practice is replacing failed implant surgery. Now, just between us, and we'll keep this all quiet, every so often, some of those are my cases. Not all of them, thank goodness, but I have to deal with some of my own failures. And sometimes I use a bioengineered product to help compensate at the time. Autogenous bone for me is just if I'm going to be making it anyway. This is a all-on-4 in the mandible utilizing a guided protocol that I use. I did one this morning. These are really straightforward protocols. The end goal, of course, is a mandibular fixed hybrid prosthesis, originally designed by Branimart. We use this on pretty much a weekly basis in the mandible and the maxilla as one of the fixed alternatives, but not the only one. Anyway, this usually involves a hybrid prosthesis is a tall prosthesis. So it usually involves removal of lots of bone. Well, this bone has value. So after I get done with my surgery on the bottom, I'm going to take that and put that up top where we need augmentation grafting. But I'll also show you that I have a hard time, let me go back, differentiating sometimes the side of my autogenous bone and some of the more available allografts. And of course, it depends on the handling that you do. But you can see their allograft mixing in with it. And then on top of that, I have found on the front of these maxillary ridges, when you're doing large horizontal augmentations, I found out that Xenograft further helps to stabilize the secondary deformation and shape changes. And therefore, you may end up sometimes with too much bone, which for the most part is a good problem to have in my world. And that's the all-on-4 patient. Now, allografts come in all forms and fashions. And of course, they're mineralized or demineralized. They're cortical and cancellous or both. They're particles, paste, putty, block, sponge, mesh, treated and untreated, meaning some type of biologic combination. What I will tell you is that there is merit to all these various morphologies of allograft. But in the end, sometimes the morphology is designed to attract the user to make it look easy. So you have to be a scientist and a doctor when you choose which ones you're going to use. For me, putties and paste are a good way to mix other particles together. Maybe not quite as much as PRF or some other things, but in the end, we have to delineate between the shape characteristics of the graft and the advantage it may or may not give you when you do the procedure. Hey, if it makes it faster and it will yield the same as a large particulate graft material, then obviously that makes sense. So for me, we have a case like this, and this is a common type of referral where I need to augment the posterior ridge, and the nerve is anywhere between 4 and 6 millimeters below the area, sometimes the buccal, but sometimes dead below where the implants need to be for proper prosthetics. So there's multiple ways to do this, and we've all done them. Block grafting, titanium mesh, ridge splitting, and PTFE membranes with titanium inserts for shape. But in the end, for me, it's a simple GBR technique using allograft. The key is to do something to help maintain the space, because rumor has it when our patients go home, they eat, they masticate. So you have to be able to do something to maintain that position. In this case, these are cortical human bone pins, which will also resorb. They're available from several different manufacturers, and they serve as my vertical augmentation for what will be a particulate allograft. But I found over the years, and I use a double membrane technique, that a xenograft on top of it helps to stabilize the shape and the final morphologic outcome of the maxillary ridge. So then obviously close, come back for another day and put in the implants. And that's the before, that's the after. Now, this is a misleading x-ray because that vertical augmentation is not my final vertical augmentation. If you look very carefully, I don't know if you can see my mouse here or not, you can see where the bone pins are. But over time, that gets compressed because patients go home and food boluses will hit it. We hold on to the patient's removed partial denture that they've been wearing for 40 years. And you can also tell that the patient has a bruxism habit. So put a partial denture over that, and you'll do a very effective job compressing your graft back down to just a little bit more than you had. For me, it's maintaining that space. And then, of course, coming through, I'm sorry for the grainy nature of that x-ray. Sinus augmentation. For me, allograft, well, first off, let me clarify. We all know that in the maxillary sinus, almost every graft that maintains a space is biocompatible and it will be replaced by bone. What's important, though, is the rate that you want that to take place. For me, for the longest time, it was allograft. Lately, I've been changing my protocols just a little bit. And this is somewhat of a, not a marketing, but a commercial component to it, where when we do the lateral walls, I will use a xenograft on the superior most portion of my graft because it's radiographic, and then use allograft in the main body where the implants will actually be. What I mean by that is, and of course, in this case, we're also doing a ridge augmentation. So, because we have both a vertical and a horizontal defect, but we can reliably count on this to be ready somewhere between 4 and 6 months later in a healthy, otherwise healthy patient that you control the compressive loads associated with it. So I use a double membrane technique frequently. And when we close, obviously we'll have keratinized tissue we have to worry about. But if you can see right here, the most superior portions of my augmentation are much more radiographic. That's immediately post-op. What I've also found is deformation or compression through pneumatic pressure of breathing through your nose is a little bit more inhibited when I use a xenograft towards the top. Yet I want the body of my implant to be primarily in what was originally allograft and has now been replaced completely by bone. This is an anecdotal statement to my knowledge. I know there's many, many studies with comparing xenograft and allograft, but I don't know if there's anything that has shown that the morphologic site gets compressed a little bit less, because, by the way, we all breathe through our nose, and pneumatic pressure is extremely powerful, and it will smash and dissipate that somewhat. But that's what I found. Ridge augmentations, for me, if it's going to have implants somewhere in it, the body of the implant, and there's another sinus augmentation, but the body of the implant will need to be in my opinion, my preference, I should say, 100% bone or close to it. So for me, allograft is the way to go. I graft the palate sometimes in these cases if I know the prosthetic treatment plan intends on being slightly to the lingual, as a lot of these full arch maxillary cases are. For some reason, we have a tendency to believe that the only atrophy that took place was on the buccal, but in reality, it's both buccal and palatally, especially if the patient has had decades of the use of a denture. But that being said, closure of that, allograft is my primary site. So when we go from this to this, we can also, fortunately, another thing I found out about allograft is that you don't have to wait for it to be rock hard. It can be hard clay, if you will, and then undergo a flapless protocol, whether it's guided or unguided. This is pseudo-guided. I used the patient's denture because I knew the prosthetic treatment plan and I knew where the dentist wanted the implants. And then in the end, and for those of you in Europe and the Middle East and Africa or the Pacific, wherever you are, this shade here is called Palm Beach White, just so everyone knows. That's a popular shade particularly for female patients who have survived their husbands and are over 70. In a case such as this, we have a high smile line patient, a very beautiful girl, you can't tell by the photograph, who had 3 press fit implants placed 15, 20 years ago, not in the best position, and then secondarily got infected. This type of augmentation is a highly aesthetic augmentation. And while pink porcelain is obviously usable, I found that if the vertical margin of the pink porcelain is mesial to the lateral incisor, it will be visible. If it's mesial to the canine, it can be better mass. So in this case, we have to build bone both horizontally and vertically by the time we debride all of the mess that's in there out. And this involves nothing more than just traditional GBR, but it'll be a 2-stage protocol. So first will be horizontal augmentation by 100% pure allograft mixed with the patient's blood. In this case, I think it was PRP. And subsequently, a typical resorbable membrane. And that's what we get. Inadequate vertical, and you can't tell, but more than adequate horizontal augmentation for the implants. And in this case, I choose to do an osteotomy protocol, which is to make both a vertical and a horizontal cut and try to minimize the exposure of the soft tissue or incision in the soft tissue. And then we will actually take this. And what's important is this is, at least in part, allograft that has now become part of the patient's bone. Once you make that vertical downward osteotomy, we utilize a bone plate of some type to stabilize it, and then we just fill the gap up with more allograft. And this is a reliable protocol for me versus block grafts, versus titanium mesh, and versus PTFE reinforced membranes if it's a large site. Now, I use titanium reinforced PGF membranes on a fairly regular basis, but in fact, I prefer these osteotomies, and in that case, I can only use an allograft. Well, let me clarify. I would prefer to use an allograft to have pretty much 100% native bone to move in the process. So on the other hand, xenografts are very important in my practice. In this case, has a fairly narrow ridge. It has a sinus elevation, which needs to be done. I have about 3 millimeters or less of bone. I use a bovine product that's held together by either bovine or porcine fibers, depending on which brand you use. And of course, again, if you have both bovine and porcine, you have to be cognizant of multiple religions. But nevertheless, it makes this a fairly easy thing to use to put in the sinus osteotomy site. But also what's more important is this is an adequate horizontal bone width on the buccal. Now, if you do an allograft in this, it will certainly, and you do it properly, it will certainly turn into bone, but I also think it'll recede. And what I found over the years, I have less gingival recession on cases like this where the body of the implant is still in native bone, but there's a high probability of a dehiscence or a recession in the buccal. In that case, for me, it is utilizing a xenograft product. And what's important here is I come back 6 months later, which is my minimum for xenografts, by the way. And we have this beautiful ridge, which if you put an explorer down in the center of the bone component, it will bleed. But yet you can still see componentry of the bovine product that's in there. So in the end, that is a tool and a means to an end. Here we have a case that is both a hard and soft tissue deficit. And what I've learned most frequently is that, and as an oral surgeon, you probably know, we start behind soft tissue management to the periodontist in the United States. So you have to catch up. We're really good at breaking faces, but we have a hard time maintaining papilla. So in the end, what I found is I can certainly do gingival grafting, both hard and soft tissue grafting, but quite frankly, sometimes it's better to use and be patient what you have. And I found in cases like this, when the root is floating, and I've learned this from a periodontist by the name of Paul Fugazzotto, that generally when you take the tooth out and all that's there is soft tissue, instead of removing that soft tissue in the socket, we instead separate it from the palatal wall, bring it forward to the buccal, and put some kind of space maintainer. This is a cross-linked collagen plug that is sold as a bone graft, but in fact, I think it works better just as a soft tissue manager. And we will develop really healthy soft tissue, albeit inadequate in terms of dimension. But now I have something I can work with. So now we'll do our typical GBR protocols. And in this case, utilize a PTFE titanium reinforced barrier membrane, but I generally use the titanium reinforced membranes with polytethyl-fluoroethylene, not as the definitive barrier to fibroblastic ingrowth, but nothing more than a skeletal form to help me maintain the curvature and the shape of the ridge I need. And I'll secondarily use a resorbable membrane over the top of that. But again, in this case, because I'm using that titanium reinforced membrane, I feel really comfortable using an allograft because I know I can go in there much sooner to do the implant. Now, soon is not a justification to compromise clinical outcomes, but soon that yields similar outcomes is a good thing in my world. And therefore, there's the PTFE reinforced membrane, clearly not covering much of the graft, but it's maintaining that skeletal shape, that side shape that you see right there. But then over the top of it, I'll use, in this case, this is porcine pericardium because it sort of drapes over the area and seals it really nice and gives me the engineering that I need. Looks pretty rough, but it comes back and we can place implants in that, and an implant in that spot right there. So, however, on the contrary, in this case, and this is a German woman in a large corporation here in Richmond, Virginia, and her bone is either thin or non-existent, multiple fenestrations and fistulas that take place. And with that, I'm going to utilize a allograft xenograft combination in conjunction with a collagen top and use the provisional prosthesis to help shape the ridge. What I found is an allograft xenograft, and this is some anecdotal, some data, an allograft xenograft combination in this area with proper vectors of load with the provisional, just a very slight flexion into that space. This is called a SnapOn smile. And there you can see the implant before and after the augmentation. I'll augment over the top of the implants and create this architecture that we can then have a better prosthetic outcome. That's a combination of the provisional as well as utilizing the graft material that does what we do. Okay, so this is where I'm going to stop and allow some discussion and or questions. Peter, if you're there.
I'm here. Thank you very much.
Can't hear you, Bob. There you go.
Thank you very much. Can you hear me?
I can hear you.
Yes. So thank you very much for this fantastic presentation. We have already some questions here. One is you talked about infection there. Do you stick with the systemic antibiotic therapy, or you also use a local antibiotic therapy by impregnation of the grafts you're using?
That's a great question. I used to put tetracycline or something similar in my grafts for years. For a little while, tetracycline was harder to get in the US, and so I stopped in the process. I use systemic antibiotics on pretty much everybody I put titanium in. Not everybody I do grafting in. And there's controversy, I know, but in the end, I guess I'm part of the problem. However, if I go into a site with the intention to either graft and or place the implant, and it's one of those sites where there's not just localized granulomatous infection, but also suppurative exudate and cellulitis of the soft tissue, I will not put particulate graft in there because particles in an infected site that also has cellulitis of the soft tissue, I have found often turns into sequestrums and problems. I will, however, use a material, and I'm not supposed to use proprietary trade names, so what I'll say is a bovine cross-linked capsule that I will impregnate in an antibiotic, usually doxycycline, and put it inside the socket to help control. And I get consistent results. And, let me clarify, when you practice an implant surgery at volume, no matter what you do, you're going to have complications. I want my surgeries to be consistent, like an assembly line designed by, well, I'll say Henry Ford, but Mercedes actually made cars before Henry Ford. So whichever company you want to, but I want it to be a consistent assembly line. I don't want my patients, do not want them to feel like they're on an assembly line, but I need consistency. So everything I am about is reducing complications, reducing office visits. And I found localized in the most infected sites, antibiotics actually does make a difference for me. And by the way, cases where you saw where there's a lot of edema, I've also found that besides systemic corticosteroids, I also found injecting dexamethasone, 4 milligrams per cc in key sites in the vestibular areas also makes a big difference with less of a systemic effect.
Yeah, indeed. So there's another question. What is your preferred allograft type in the GBR?
So if it's GBR, remember GBR is a generalized term, but if it's a ridge, if I'm going to make a skinny mandibular ridge fat, my preferred allograft is a cortical cancellous mix of mineralized, demineralized. Now, I used to use just mineralized, and I will tell you that that absolutely positively works, but I found, and there's some data, I'm not sure how clear it is, that shows if you add a demineralized component, it has a little bit better mineral density later. The thing is, demineralized graft early on, they obviously have the potential to release bone morphogenic protein, but they also resorb away too fast. Hence, for a decade and a half, I was using just LifeNet mineralized bone. But now I found a combination of those things makes a difference.
Yes, especially in the special age group of patients when you go to the osteoporotic site then. So what are something you can recommend for wound closure over significant graft volume?
So you're talking about taking a skinny ridge and turning into a fat ridge and getting primary passive closure, right? Is that what you're asking? Okay. I utilize a protocol called the Cinch suture technique, and this we teach this in a grafting class that I give up in Boston with Paul Fugazzotto. And I utilize a suture that slides, and it's either going to be PTFE suture, the old Gore-Tex, now it's called Cytoplast, or a newer material called glycolin, which is the same material that Vicryl is made of, but it's not braided, so it's a monofilament. And the key is that you have to have it slide. And I'm able to actually take one pass above the membrane and then cinch it shut and then go through the membrane. And so the membrane's tacked superiorly and the membrane's tacked inferiorly in the maxillary ridge, for instance, with the suture.
Absolutely.
And so the key to success is more passive release than you think you need, because you have to anticipate the edema. So primary closure is no good if it's not passive primary closure, because if it's primary closure and the patient has edema, pretty soon you won't have primary closure in there. So, yeah.
So last question, what is your preferred allograft for use with a titanium mesh?
Doesn't matter. It's the same.
Doesn't matter, yeah. It's
the vast majority of my membranes are resorbable, either bovine or porcine, but it's important to note that a PTFE titanium reinforced membrane for me. Now, again, I teach with a periodontist who that's his primary go-to. For me, that is a very special niche. When I need to make this angle in the anterior maxilla, in the posterior mandible, posterior maxilla, I overcompensate by too much size. Even though it rounds in, I have more than I need. I much prefer resorbable membranes in that case. But the membrane in my opinion, the only way the membrane is affected by the graft is if I'm using a heavy xenograft, I realize the membrane needs to be there longer because the process will take longer.
Yeah, and the last question, maybe not because of the religious use, but if you look to the better handling, what is your preferred fascialata or pericardium? What is, in your opinion, the porcine?
Porcine, yeah, porcine stretches. We have to make sure we understand there are membranes that shape the graft, and there are membranes that shape to the graft. Porcine pericardium, or all the pericardium ones, shape to the graft. What's special about that is it seals the edges, so lateral infiltrations of fibroblasts is diminished. But the ones that are more like construction paper, the resorbable bovine membranes predominantly, shape the graft, as obviously does PTFE shape the graft. But in the end, they both are valuable tools in your big ridge augmentation. And by the way, I'm not implying you have to buy all this stuff. When you start out, keep it simple. For the record, I will tell you, if you only had one graft to use, an allograft will fulfill more roles. A cortical cancellous allograft, or for instance, a cortical min-D-min combination, has almost the same shape deformation characteristics as bovine, not quite as much, but almost. So if you have to have one product, it would be an allograft. For me, I have to have a bunch of products in what I do.
Yeah. Okay, thank you so far. So I would just ask. Oh, you're still sharing your screen. So for the patient's acceptance of the, allograft, I will go to silent and mute.
So we want ROI. Now, ROI, if you listen to CNBC in the United States or any of the financial networks, Bloomberg or whatever the financial networks are on TV in your respective countries, constantly the term ROI is used, return on your investment. Now, for me, ROI is very little to do with financial, but to do with the time, the stress, the amount of difficulty utilizing, the what you have to do to stock the product. I want to have a good ROI. I want a good ROI on my graft. I want to be able to put in a cc of graft and get close to a cc of bone. For the record, don't tell anybody, I almost never get that kind of ROI, right? But if I get 80% ROI, return on my investment in graft that turns into bone, that's a successful thing. But let's talk about the patient's ROI, the ROPI. So we think about their bone volume, their narrow ridge, their keratinized tissue, their probing depths, the sinus pneumatization. These are the things that we think the graft is necessary for. The vertical bone height. Here's a secret. Patients don't care. They don't care about all that. They want to know, will it make things last longer, work better? In the end, the graft that you're going to put them through, which involves money, pain, time off from work, swelling, and possibility, the risk of failure, is nothing more than a means to an end. And it's a means to an end to have an implant. Now, by the way, patients don't really want an implant. They want a tooth or teeth. So your grafting, even though we worship the concept of grafting, is nothing more than a means to an end for these patients. We have to always keep that in mind when we talk to our patients. You can spend all of your time justifying why you're going to use one product over another and why it's necessary. But if you use science and decision tree rationale, that's irrelevant. You have to start from what the patient wants. So they want teeth. They want it to look good. They want to be able to eat with it. They want it to last, and they want it to last as long as they do. Now, I will admit that there are cases that when I have someone who has a life expectancy of 3 or 4 more years, maybe I'm less concerned about papilla. But in the end, we have to put ourselves in the shoes of the patient. Now, I'm tasked to talk to all the group out here about how to talk to patients about utilizing allografts. So what I want to make sure is you understand this is the same protocol with every part of our treatment. From beginning to end, we have to put ourselves in the minds of what the patients have to go through. These patients that show up with these problems, and she's had previous implant experiences and she's probably had tens and tens and tens of thousands of US dollars to go through this and still be here. Why does this happen? It's multifactorial. It could be systemic. It might be the dentist. Of course, the patient plays a major role here. It could be the lack of diagnosis of the parafunctional bruxism that takes place, but it doesn't matter. These patients are coming to you, and whether they show it or not, they have a high level of fear. So we need to carry them down the road, not only to properly treatment plan them, but if you're going to also discuss about grafting, that scares patients. And a lot of times they can go one way or the other. They can go this way and have this treatment, or they can go this way and have another treatment. For us, it's clinical choices. For them, it's a scary road. And you have to make sure you understand how they feel. You do that by making a connection with these patients. You do that by letting them know that you know how scary this is. So we want to guide them to a nice, beautiful, straight path. So they come out to this euphoric view and they have this outcome that everybody's happy with. Well, it's not that easy. The key is you could be the best technician in the world, the most accomplished hands touched by the almighty deity of your choice. But in the end, if you don't put yourself in the shoes of the patient and really let them know that you understand, you're not going to get that much accomplished. So therefore, you have to make an assessment. You have to understand, what are their fears? What are their expectations? Are those expectations realistic? What are their motivations? Why are they doing this? What is it? Do they want to eat? Do they have a wedding they want to go to? Are they tired of their kids telling them that they look terrible? Whatever the motivation is, you need to know that before you do anything. You have to be able to tap into what their understanding is, because false information, especially everybody in the day of YouTube, most of my patients have seen my procedures on YouTube, not my procedures, but the procedure I'm recommending. And I don't know if it's been done right or wrong. I don't know. But in the end, assess their understanding of what they have so far. Assess their need for further info. I will tell you, some people don't want to know much. They just want to know if you're going to take care of them. Other people, engineers, people that are the OCD types like me, people that have issues of control, they need to know everything you can tell them. And the more you tell them, in their case, they're happy. And you have to be careful how long your consult takes. We have to speak with clarity. We have to clearly look confidence. Patients can read your mind. Now, this goes to the fact if you've been using a xenograft and an alloplast for most of your career and you now want to use an allograft, then you've got to believe in it before you tell the patient to believe in it. They can see it in your eyes. The only way you can develop confidence is to be able to understand completely and thoroughly all the innuendos, all the componentry associated with allografting. You have to give them reassurance. Obviously, there's multiple reasons why people are not, that they're somewhat unsure of human graft materials when they haven't seen many people go that. Now, what's most important, the most important caveat I can tell you is we have to give patients a sense of control. The loss of control is the most fearful thing for most of these patients. So no matter what, the patient can help guide it. Now, in reality, I've learned to manipulate the patient's mind to want what I want them to have. But that's not always easy. But the mission is somehow give them a sense of control. And that goes into discussing the types of graft materials that we're going to use. So to make a connection, lead with your ears, listen to them, understand where they're coming from, listen to that vital information they give you. Assess the things I talked about before. Always eye contact, and very early, from the minute you walk in, some type of very gentle, unintimidating physical contact. For me, it's sometimes the cheek when I'm theoretically checking the TM joints, but I'm gently sort of caressing the side of the face, or the back of the shoulder when you talk to somebody. I like to sit down and be at or below the level of the patient when I talk to them. And if they're sitting with their feet in front of me, I'll actually touch their shoe while I tell a joke. Somehow they need to feel some kind of physical connection with you that is not painful and intimidating. You need to speak with clarity, confidence, and reassurance, as I said previously. Be able to explain how it's safe. Now, in order for that to take place, you have to understand how it's safe. You have to speak with tactical mimicry. This is a technique that I've learned through a bunch of things. There's a book by a famous author here in the United States called Dan Pink. He's wrote a bunch of business books, and one of them is To Sell is Human. And he talks about tactical mimicry. Waitresses that repeat back the order that you gave them after they take your order without writing it down have 70% higher tips. Tactical mimicry is we will have similar body language. We will have our voice volume similar to theirs, not higher, not lower. We will also speak as fast or as slow as they do, and sometimes even use terms they use to make them feel comfortable. Doctors are terrible at this. And by the way, I'm an old dude. I've been doing this a long time. It took me a long time to understand tactical mimicry when you're talking to the patients. Let them have some control, something to do with the choice of timing, of maybe even which product you use. For me, I like the patients to understand the graft materials enough to have some control if they want to talk about it, but also let them know what their responsibility is. By telling them that part of this success is up to them, it gives them some kind of sense of ownership, but also helps you when they weren't compliant, when they went home and bit right into your graft with a Chipotle chip. I don't know if Chipotle is a restaurant here in the United States that has these chips that are like razor blades. They could be used for carotid surgery. Anyway, if they need to take responsibility. It's a shared responsibility for the outcome. So terminology, what word you use, not cadaver, donor, your voice inflections, and your body language. So what keeps patients from treatment? Well, certainly access is probably some of it, but it's not just access to the doctor or the fact that the nearest doctor is 250 miles away. There's also access because they were told that it couldn't be done. The graft could be done. They can't have implants because they don't have enough bone. I probably will tell you that this makes up about a quarter of all my patients are told it can't be done. Fear, obviously. There's really fears. There's multiple fears. The fears of obvious pain, fears of how much time it will take, the fear of the graft failing or not taking, of getting some type of disease, the fear of spending all this money. Financial fear is huge in the process. And then, of course, confusion. People are told so many things and they read so many things. Today, in the information age, it's overwhelming. So access is not just physical access. Access is also, they told it couldn't be done. Fear and confusion. Is it safe? Where does it come from in terms of the graft material? How long will it take? Which one is better? You have to be able to have an understanding. My lines often are, you know what, they'll all work here. The only difference is how long it'll take. So if we use this product, it will take this long. If we use this product, it won't. Frequently in conversations, they'll say, I don't want any of that human stuff. I've also had the opposite. I've had patients in that 7% of failures I see say, he used that stupid cadaver bone on me and that's why it didn't work. Or I've had a patient say, they used pig bone in me and I'm Jewish and he didn't ask me or anything. That's the reason why it failed. We all know that the material is seldom the reason why it failed. But which one is better? Tell them the pros and cons of each and make them think they're helping you make the decision. You can sort of lead them or guide them. So what this is a copy or a cut, of the video that's available for you guys to all see how the AlloWash XG protocol goes. In other words, how is this graft made safe, this allograft? And in the summary, it's obviously, very effective screening. They recover the graft samples in a very aseptic protocol. The serologic testing is compared to nothing else. It's phenomenal. Removal of the blood, lipid, and marrow products in the process is through a triple, if not more than that, wash protocol. They solubilize and remove it. Then they decontamination and clean it, and then they use gamma radiation. Well, most patients don't want to hear this. But you, all of the doctors out here, have to understand, if you're going to use this product, how this takes place. And once you know how to take place, you can actually customize this into as few as 2 or 3 sentences that make sense for that particular patient. Make a connection with your patient. I don't mean make them like you. Make a connection. Become one that you guys are shared members of a team to accomplish a mission. Once you do that, well, heck, 95% of the patients don't care which graft I use. But the ones that do, you have to be able to make them feel comfortable. For me, I always mention that gamma radiation destroys all HIV and hepatitis, but I also talk to them about the delipidization to remove the chance of having a rejection that there's nobody's DNA in this graft. So it's basically bone that is the same shape as your bone, but it actually works in anybody's head. And your bone will go into it, and your bone will actually lay down a scaffolding initially of capillaries, which then lays down bone cells, and eventually it will dissolve away the graft and it will be your bone. Whatever you want to do, but listen, you can't have the same spiel for the same patients. You have to customize the conversation with the patient. The same concept of connecting with the patient is the way you sell them large cases that they need. It's the same way you convince a patient to follow some instructions they don't want to follow. In the end, is making a connection. So it's rendered sterile. The most important thing is this allograft is rendered sterile through this process. And you can tell them it's a 7-part process or a 10-part process or whatever you want to tell them based on the facts, obviously, because there will be, by the way, some people that will look this up. So if you say something that's wrong, then that'll be an issue. So for allografts, terminology is key, such as donor versus cadaver. Remind them that allograft will be completely replaced by your bone. Focus on the time advantage that allografts give you. Allografts, for me personally, have executed near the same result as autogenous bone, but without the harvest site. So Mrs. Smith, instead of taking your bone and making you have 2 places that hurt, we'll put it in one spot and have 1 place that's sore. In the end, they will both be about the same. Now, that's not always true, but most of the time in my day-to-day, it is. Use prudent terminology appropriate for that specific patient. Use your connection skills. Make them part of the team, meaning make them take ownership of their part and define their roles to achieve success. Mrs. Smith, you were referred for us to place implants and help you restore your bite and your smile. In order for us to do this for you, we need to bring back some of the bone you've lost in that area. The great news is that we do this successfully every day, and we can do it for you. Would you like to talk more about it? Now, for the record, when a patient says they don't need to know, I still mention, and I have a notation in my chart that we mention the different graft types. And for me, I used to be much more detailed than I am now. When I discuss graft types with patients, I basically tell them that there's 3 types of bone. Well, we know there's more than that, but it's autogenous bone, your bone, donor bone, and then one of the artificials. I put xenografts in the artificial category because it's not from them, it's not from a human. But obviously there's a difference between xenograft and alloplast depending on the product you use. And so if they say, I don't want any of that human stuff, says, well, no problem, we can use this. But of course, this is going to take about 3 to 4 months longer. And you could even make it 6 to 8 months longer. You would not believe, but I would tell you that probably 90% of the patients, when they hear that, want the donor bone. Now, very few patients ask for autogenous bone anymore in my practice. A few do. And it's kind of okay because I like doing it every so often, so I have the skill set. But I make them know that they're going to have twice as much swelling, especially if I'm doing a ramus graft, or especially if I'm taking the bone from somewhere else. And again, most of my autogenous grafts today are merely, as you saw before, a ridge reduction for a prosthesis, or I use a material called, or a burr called the Versa burr, which does osseodensification, and we expand the bone. So that's in essence almost like an autogenous graft. So let me stop right now. It's 3:01 in the US here, and answer some questions.
Thank you again. This was a fantastic talk, and I have to tell you that there are even some participants, they want to give you all the compliments about your talk. Smart business, fantastic motivational speaker, and yeah, I have to say the same. So nevertheless, there are some questions. What do you tell a vegan patient who should have a xenograft under the bridge?
Tell a what patient?
Vegan. Vegan.
Vegan. Oh, okay. Well, so let me just tell you this. I had this conversation with my daughter. My daughter's a vegan. And I said, well, baby, no problem. I can use, oh, by the way, my daughter said, you're not going to put that cow stuff in me. That cow did not sign consent. I said, okay, baby, I'm good with that. But now listen to me. If I use the human bone, it's going to work. But here's the thing. you realize that about 5% of the graft comes out during the maturation phase. And, the patient swallows it. So instead of having bovine swallowing, are you going to become a cannibal? And so that, all kidding aside, you tell the patient the pros and cons. In the end, there's very few places where an allograft can't do what a xenograft did short term. Now, long term is the question. And in an area where a xenograft, for me, high smile line, female patient, fairly thin gingival biotype, at least part of my graft in the aesthetic zone is going to have xenograft involved with it. A lot of the times I use xenograft, it's convenience for me, or it gives me a more refined ridge. But in none of those cases can I not use that. So the fact that you're concerned about the vegan's beliefs is a huge endearing connection with the patient. That's a beautiful thing. So you let the patient know, okay, if we use, for instance, if it's maxillary right canine, I don't know what the international system is on that, and when they smile, they show 2 to 3 millimeters of marginal gingival display. It says, we definitely can use it. The implant will be just as strong, but in years 2, 5, 7, and 10, you'll notice some compressive load because form follows function, and you'll see a little dent over the top of the tooth, which overhead light will make a shadow. Does that bother you? Suddenly they say, okay, use the xenograft. It just kind of depends.
Yeah, absolutely. How important is your confidence to your patient's treatment acceptance?
In other words, what's my acceptance rate?
Yeah.
High 90s. I like to get rejected a couple of times a month, so it humbles me. So I try to hone my skills. But I mean, I will tell you that I have never, to my knowledge, been, when I insisted, one of the things I didn't clarify was, if it's a graft that I think any one of the categories will work, I let the patient make a choice. And when they make the choice, I say, okay, so now tell me what that means. I'm going to give you a quiz. If you choose to use bovine instead of human, what does that mean? And if they say it's going to take 2 to 3 months longer, whatever the reason is, if they say that, and I think I can execute it that way, they have ownership. It's a beautiful thing. Where you're describing is where what you want is not what they want. But the key is to make them want what you want for good clinical reasons, not to be stubborn, not to be obstinate, not to be overpowering. So you realize, for instance, I had a veterinarian 3 weeks ago, refused human products and used any xenograft product at all. So I used Alloplast. And I said, Carol, and I won't violate her, obviously, her confidence, Carol, you realize that we may not be able to be done here for more than a year. Is that okay? And she said, fine. Well, then I used Alloplast in there. So.
Yeah. I think one of the biggest challenges we are faced to is that we have, as you said, a lot of information we can suck up, or the patient can suck up from the internet, and then they come with an expectation to you, to your clinic practice, and the expectation is, I saw this in the internet, I want exactly this, without knowing their bone health, their pathology. So, and then you come into the discussion with them and to explain what is the best for them. Sometimes it's not accepted.
Well, and what you have to do in these situations is do not start out by being confrontational or offended in any way. On the counterpoint, be exquisitely excited about that. Well, that's neat. So wait, did that patient have the same kind of defect that you had? And did that patient have 2 previously infected root canals in that site? Because that does make a difference, when it all said and done. But never poo-poo the patient's thing. And never tell them they're wrong. And by the way, say, you know what? I see things on YouTube all the time. I have some things on YouTube. And you know what? At least 1/3 of those are really accurate. I didn't say the 2/3 are inaccurate. I said at least 1/3 is accurate. They come to the conclusion and realize, wait a minute, this guy does this, I'll follow his lead. But you know what? The patients make the decision to agree with you or not is almost never the facts of the disagreement. It's how we handle the disagreement and how we make them feel for challenging us. I love the patient to challenge me. And I love the patient. At some point in time, we all have to, it's quarterback and running back, sorry, US football term. It's the leader at some point in time, you turn it over and let the expert do their job. But I love my patient challenge. I never make them feel bad for disagreeing with me, but I manipulate them.
So there's another question. What was the book you recommended about the better communication?
It's Daniel Pink, P-I-N-K. He used to write speeches for Al Gore, and he was on the staff at Yale. To sell, in the US, S-E-L-L, is human. To sell is human. I know we're running out of time, but here's a good story real quick. A shoe company sends 2 people to Africa to see the prospect of selling shoes. This is in the late 1800s. One guy calls back up and says, you can't call, whatever it is. Maybe it's 1920. It's hopeless because no one there wears shoes. It's hopeless. Another guy comes back and says, it's the best opportunity everywhere. Everyone needs shoes. The same exact thing. When we talk to our patients, we have to understand, connect with their mindset. All of your intellect, all of your experience, all of your skill, all of your reputation, that means about that much to them. You need to have a connection that they feel like they can trust you to go.
Absolutely. Absolutely. And I just have to repeat one of your listeners today. You just made my day with this presentation. Thank you very much again, Dr. Keeney. I would like to thank you for today's appearance here on our stage. I would like to thank all of our presenters during the last LifeNet Health Global Virtual Dental Symposium. We had